Так, the next presentation, Professor Kim from South Korea. Uniportal endoscopic approach for degenerative thoracic disease. You know Professor Kim, many books, you know his activity in the world. Professor Kim.
Hi everyone.
See you. Are you ready?
Yep.
Are you ready?
Yeah, please play the video.
Yeah. Okay. You can start.
Good afternoon, ladies and gentlemen. I'm Hyeun-Sung Kim from Hyeun-Sung Spin Arts Hospital, Cheongdam, South Korea. First of all, I am honored to be able to lecture at the 21st International Symposium of Minimally Invasive and Instrumental Surgery of the Spine. I would like to thank Dr. Lodchenko and the staff for inviting me. First of all, I would like to congratulate the successful 21st International Symposium of Minimally Invasive and Instrumental Surgery of the Spine and introduce the new name of a spinoscopic spinal surgery as a spinoscopy. Here is my curriculum vitae and disclosure. Advances in medicine have significantly increased human life expectancy, and as a result, degenerative spinal diseases have also increased rapidly. This has led to a rapid increase in the existing degenerative spinal stenosis disease, and successfully resolving this will be our role and effort for a happy future for mankind. In particular, with the remarkably development of spinoscopic spinal surgery, spinoscopic spinal surgery can now be applied to most degenerative spinal disease, and in particular, the development of the spinoscopic spinal surgery in the thoracic area is expected to be a very important part in completing spinoscopic spinal surgery. The core and purpose of spinoscopic spinal surgery for degenerative spinal disease are considered to be two things. The first is the mobilization of the working channel with two Uniportal spinoscopes, one small and one large scope. In the second core and purpose of the spinoscopic spinal surgery will be to create a wide working space. And these two core points have already been successfully implemented through mobile technology and foraminectomy. Now let's learn about the surgical technique of spinoscopic spinal surgery that can be applied to degenerative thoracic disease. Spinoscopic spinal surgery has evolved into 4 generations, and in the thoracic area, in addition to transforaminal and intraminal discectomy, all 4 generations of spinoscopic decompression and spinoscopic fusion surgery techniques are applied in the surgical process. As shown in the figure introduced by Dr. Sebastian Retten, full spinoscopic spinal surgery can be performed through three access routes. First, transforaminal, second, intraminal, and third, posterolateral. You can see here. Therefore, in degenerative thoracic disease, disc pathology can be resolved through small scope TTD and ITD, and stenosis and instability can be resolved through large scope T, ULBD, and TTIF, thoracic transforaminal interval fusion. First, let's learn about the techniques of TTD and ITD, transforaminal and intraminal. The transforaminal approach at the upper thoracic level is fully explained in Dr. Best's paper, which shows that most thoracic disc pathology can be resolved through spinoscopic spinal surgery through the transforaminal approach you can see here. In addition, to successfully perform the transforaminal approach, sufficient foraminotomy is essential, as illustrated in this figure, to achieve a wide working space and sufficient mobilization. You can see here. First, spinoscopic decompression of thoracic spinal stenosis for spinoscopic decompression of thoracic spinal stenosis. It is especially important to maintain an outside-in over-the-top approach, which allows for effective bilateral decompression. However, in the cases of thoracic stenosis, since the nerve are often already damaged or compressed, caution must be always to be taken. Nonetheless, in degenerative thoracic spinal disease, it is important to fully master these techniques, as they can be used to successfully treat even complex and difficult regions by integrating the techniques of TTD, ITD, and TULBD. So if thoracic interval fusion is required, the problem can be successfully solved by using spinoscopic transforaminal interval fusion using the posterolateral approach that I have already introduced in the lumbar interval fusion. In particular, in the cases of decompression in spinoscopic spinal surgery of the cervical thoracic region, the function of spontaneous bone remodeling is very excellent. So it is very important to perform sufficient decompression first, rather than considering the damage to the facet joint that is known to exist. In this patient case, it can be seen that bone remodeling is very effectively after 1 year of follow-up and 2 years of follow-up, you can see here. And let's discuss whether spinoscopic spinal surgery can effectively treat for degenerative thoracic spinal disease through case studies. This 42-year-old male patient presented with thoracic pain and left leg radiating pain. And the disc pathology was effectively resolved through transforaminal endoscopic thoracic discectomy. As shown in this figure, performing sufficient foraminotomy in TTD of the thoracic area can secure sufficiently mobilization and working channel space, resulting in a safe and successful procedure after operation. 1 year follow. Central located thoracic HMP is not easy to surgically approach, and even in the transforaminal approach, the lesion can be safely removed only after sufficient foraminotomy is performed and the central disc is carefully exposed. In this patient case, the process of removing the lesion after sufficient foraminotomy is performed and the thoracic spinal cord is carefully separated and can be confirmed. Now, here performing the foraminotomy sufficiently, then you can see the sufficient foraminotomy. After drilling, you can success the sufficient foraminotomy, and you can see here the exposed spinal cord. That means that it already sufficiently foraminotomy can done, and then you can see the pathology part of the located in the central area, and we can remove it safely. And the post-operative, you can see it successfully removed. Transforaminal spinoscopic discectomy can be performed effectively even at the prothoracic level. In this 47-year-old female patient came to my hospital with a severe thoracic area pain with a mild weakness. And we performed a transforaminal approach, and the working channel was positioned at the lateral border of the facet. And after sufficient foraminotomy, the working channel was approached to the target point, and the lesion was effectively removed. You can see here. This 51-year-old male patient visited our hospital with severe thoracic and low extremity pain. The hook big sign suspected of intradural disc was confirmed on preoperative MRI. The intradural disc was maybe suspected, and we applied to the transforaminal approach. And the intradural disc was safely removed through a mobile outside approach using sufficient foraminotomy. After foraminotomy, you can see the part of some adhesion point. After then, you can see some dural tear point. After then, you can see the huge rupture disc here. After removal, and it was confirmed that it was effectively sutured using a taco shell patch. You can see here. After removal, you can see the free spinal cord area, and then it dural tear cured by the taco shell patch. You can see here. after operation. Things to keep in mind in decompression surgery due to thoracic spinal stenosis are that an outside-in over-the-top approach should be used. The use of punches and RF should be minimized to minimize cold injury. The floating lift-up method should be eliminated to remove the ossified ligament flabum, and sufficient bone work should be performed to secure sufficient walking space. This patient is a 31-year-old male patient who visited the hospital with thoracic pain and radiating pain to both legs. The ossified ligament flabum was removed using the outside-in over-the-top technique. When removing the ossified ligament flabum, care must be taken to lift and detach the floating ossified ligament flabum after sufficient drilling, and then remove it. Now you can see the severe ossified ligament flabum here. And you can see the drilling for the boundary of the ossified ligament flabum and bony structures. Now drilling the contralateral side. Firstly, the lift up method should be used, and then remove the ossified ligament from the outside. And you can see here we do not use the punch, did not use the punch, only outside in over the top technique. First, already we removed the ipsilateral side, and now we approach the contralateral side. And drilling the contralateral attach point of bone and ligament flabum, and after sufficient drilling, lift the method using, and then pathology sufficiently removed from the severe ossified ligament flabum. After operation, another cases of ossified ligament flabum cases. In some patients, the stenosis of the cervical area is accompanied or region occur in the upper thoracic area. This 39-year-old male patient visited our hospital with gas disturbance due to spinal stenosis with myelopathy at T23. After spinoscopic decompression using the outside-in over-the-top approach, gait disturbance was significantly improved. In this another 54-year-old male patient with cervical stenosis, spinoscopic decompression using the outside-in over-the-top approach was also able to significantly improve the patient gait disturbance. This case is a very interesting case. Decompression using a spinoscopic approach can be effectively applied to cervical thoracic stenosis with acute paralysis patient, as rapid post-operative rehabilitation is expected. This patient is a 64-year-old female patient who came to the hospital with low extremity paralysis due to ossified ligament flabum. The patient underwent spinoscopic decompression using an outside-in over-the-top approach for thoracic spinal stenosis with myelopathy. She underwent rehabilitation through skywalk system after spinoscopic decompression, and her paralysis recovered to the point where walking was possible 3 days after surgery. And 6 months later, spinal stenosis was sufficiently improved. The patient recovered to normal gait. And 6 months later, MRI view, you can see here the spinal stenosis decompressed very successfully. Some patients present with complex thoracic spine regions, so let's see how to effectively address them. This patient, a 66-year-old male present with progressive paralysis of the lower extremity due to thoracic 9-10 stenosis and intervertebral disc rupture. First, spinoscopic decompression using a large scope was performed, and then the ruptured HMP was successfully removed using a small scope. This you can see the post-operative MRI. The paralysis of the limb was improved significantly after operation, and he is now back to normal life. In particular, the removal of the ruptured HMP can be performed in conjunction with the transfemoral approach, but in this case, it is important to perform sufficient spinoscopic decompression to improve the paralysis, and the intramural approach using a small scope is performed using this sufficiently decompressed space, allowing easier access to the lesion site. Now you can see the decompression. But you can see we always drilling first and not insert the punch to the abdominal space before finishing the drilling. And now you can see the severe ossified ligamentum resection to here. Remove it. And then central spinal stenosis decompression successfully finished here using the outside in over the top approach. And then change it to the small scope after drilling of the some calcified points and making the some sufficient working space, then make some traction. Now we use the small scope and soft traction, then you can see the rupture disc here. Finally, we remove the rupture disc here. So now we can see the free spinal cord area. This 38-year-old male patient was admitted to our hospital with the paralysis of the lower extremity due to spinal stenosis at the T11-12 level with calcified HMP. First, sufficient decompression was performed using a large spinoscope, and then an intraluminal approach was performed using a small spinoscope. Through this, the ventral calcified region was sufficiently removed effectively recovering the advanced paralysis. In particular, it is very important to safely remove the ventral calcified disc using a drill. Now you can see the drilling of the calcified disc here, and after operation, and this you see sufficient decompression. This patient is an 83-year-old male patient who visited the hospital with progressive low limb paralysis. Preoperative MRI showed spinal stenosis and ruptured HMP, which was accompanied by myelopathy. Fortunately, in this patient case, spinoscopic decompression using a large scope and intravenous discectomy using a small spinoscope were performed together. And the surgery was successfully performed. After the surgery, the patient paralysis was significantly improved. Interval fusion can also be performed in the thoracic spine using a spinoscope. Let's talk about it while looking at a case. This patient is a 67-year-old female patient who underwent deformity surgery at another hospital several years ago and recently visited our hospital with symptoms such as low limb paralysis, back pain, and severe low limb pain that has been ongoing for about a year. The patient preoperative X-ray showed severe kyphosis, and the MRI showed severe nerve damage due to spinal stenosis caused by a very large ruptured disc at T12L1. In this patient case, interval fusion was inevitably performed, and after removing all existing load, a single-level interval fusion was performed on the lesion site. The patient paralysis and kyphosis did not improve significantly immediately after surgery. But after performing rehabilitation using a skywalk system, the patient kyphosis significantly improved over approximately 4 weeks. This 4 weeks later, the patient walking is possible, and after 2 months later, the patient discharged by walking by herself without any assistant, some stick assistant only. In conclusion,
Thank you very much, Professor Kim.
due to the increase in the elderly population and the development of the diagnostic device, the number of degenerative spinal discs in the thoracic spine that require surgery is also rapidly increasing. In the past, even in case where surgery was required due to degenerative spinal discs in the thoracic spine, it was difficult to easily decide on surgery for various reasons, and the surgical results were often poor. However, the development of the spinoscopic spinal surgery has enabled a multifaceted approach to the degenerative thoracic spinal lesion that requires surgery, and the successful surgical results are being achieved through this.
Professor Kim, thank you very much for your
Yeah, thank you so much.
beautiful presentation. See you.
Yeah.